Thank you. I would like to thank the organization committee for inviting me and speak today about current developments in neonatal cardiopulmonary resuscitation. I just want briefly to disclose that the work I do is supported by several funding agencies, and I'm also a member of ILCOR since 2015. Now, the next 25 minutes or so, I would like to talk a little bit about what we currently do and what new evidence has evolved over the last little while and what will be our future developments and which way we are going. I think you all know that the majority of newborns make their transition successfully. They don't need any help. Roughly around 10% of newborn babies, they do need respiratory support, which remains the most critical step of neonatal resuscitation. Now, the general need for chest compression and or medication like epinephrine in the delivery room is really rare. It's estimated around 0.1% in term infants, but can also go up to about 15% in preterm infants. This altogether still results in roughly around 1 million newborn babies who will die annually around the world as a result of needing chest compression. Now, when you receive chest compression and epinephrine, there's a high incidence of mortality, which is around 41%, and there's also a lot of short-term neurological mobility, including HIE and seizures. And if you continue to do chest compression for 10 minutes or more and have no signs of life at that time, 83% will die, and 93% of the survivors will suffer moderate to severe disability. Now, this poor prognosis, which is associated with receiving chest compression alone or with medication in the delivery room, raises the question as to whether improved chest compression methods specifically tailored to the newborn could improve outcomes. Now, the main issues we had over the years is our inability to predict which newborn will need chest compression, the infrequent use of chest compression in the delivery room, which have limited us to perform rigorous clinical studies to determine the best method for delivering chest compression to the newborn. Now, what's the current situation of the current guideline? Well, if you look at the current resuscitation guideline, you will see that it recommends 90 chest compression and 30 inflations per minute in a 3-to-1 compression to ventilation ratio. Those chest compression and ventilation should be synchronized to reduce the potential of interference with tidal volume delivery, which then would cause us an impairment of oxygen delivery. What we don't know yet is what's the most effective chest compression to ventilation ratio, because this remains controversial. Now, on this graph, you see resuscitation using 3-to-1 technique. What you can see is an inflation, and then the start of the first chest compression, you see an inflation here, the start of the first chest compression, the second and the third chest compression, and then again an inflation, first chest compression, second chest compression, and third chest compression. So the 3-to-1 chest compression to ventilation ratio. Now, the international guidelines, they also always publish some thoughts about knowledge gaps, and you can see here that there's a lot of things, including how many ventilations should be done to achieve optimal ventilation, how many chest compressions should be done to achieve the adequate pressure you need for coronary perfusion, and should we do interruptions or should they be limited during resuscitation. Why are we doing 3-to-1? Well, the rationale for 3-to-1 is that compared to adults, for example, or children, there's a higher physiological heart rate, 120 to 160, so we need a higher rate of chest compression. There's also a higher breathing rate of 40 to 60 per minute, so we should add a few more rescue inflations. the profound bradycardia or cardiac arrest is normally caused by hypoxia and hypocarbia and not by a primary cardiac issue. Therefore, it seems more likely to be beneficial if you provide ventilation in addition to chest compression. What we don't know, as I said before, the optimal chest compression to ventilation ratio to optimize coronary and cerebral perfusion while providing adequate ventilation. That remains unknown. Now, Manikin studies have tried to study a lot of things, including 3:1 compared to 9:3 or 15:2 compression to ventilation ratio, and found that if you do 3:1, you have a higher minute ventilation, and the main reason for that is because you're using more ventilation, because you have less chest compression, which means you get more ventilation down. Your minute ventilation is higher. When you do continuous chest compression and then just add 30 deflations, which are non-synchronized, you even get a higher minute ventilation. But regardless if you do 3:1 or this continuous with non-synchronized ventilation or CCAV, you get roughly the same tidal volume delivered with them. So tidal volume delivery is often good when you use, it's often good in the Manikin studies. Now, when you combine chest compression with ventilation, which has been shown many years ago, that improves return of spontaneous circulation or ROSC, as well as your neurological outcome at 24 hours when you compare that to ventilation or chest compression alone. So we know that you need both to be successful. Animal studies also investigated if you're using 9:3 versus 3:1 makes any difference, and they found no difference in return of spontaneous circulation time, also no difference in any diastolic blood pressure. We also said, okay, maybe we do even 15:2. Once again, no difference. It also seemed that the 15:2 had even a longer, which was not significant, but had a longer ROSC time compared to 3:1. Therefore, I think we can conclude that the higher CV ratios did not improve outcomes. Animal studies also investigated, okay, let's do continuous chest compression with non-synchronized ventilation, so CCAV. Once again, there's no difference. There was similar minute ventilation, even though CCAV had a smaller one, but it was not statistically significant. The ROSC time was quite similar. Maybe there was a trend to a lower one, but it was not, again, statistically significant. Survival, similar thing. Tidal volume delivery is similar. However, what is very interesting and hasn't been reported previously, that when you do your 3:1 chest compression to ventilation ratio, you have a loss of of roughly 4.5 mils of tidal volume for each cycle. And if you do CCAV, you have a loss of around double that amount, which could have some effect on lung aeration, because if you lose tidal volume doing chest compression, potentially you de-recruit the lung, which could hamper your oxygenation and can hamper your time to achieve ROSC. Also, there's always this concern that when you do non-synchronized chest compression, you might affect the tidal volume delivery because you squeeze the chest, and instead of getting air in, air isn't coming in. Well, for one thing, we can say true, air is coming out when you do chest compression, but it's only 25 to 30% of inflations are impaired or affected or reduced when you do chest compression. And that happens in the 3:1 if you try to coordinate, as well as if you do CCAV. So it seems that CCAV has no advantage compared to 3:1. Just to focus once again on the tidal volume loss. So this is from an animal study we did, and what you can see here is that you see a tidal volume delivery to the lungs, with a good total volume per kilo. And then you see the expiration, which happens once you release the T-piece, as well as the start of the first chest compression. Then there's a second chest compression. During the recoil phase, a little bit of air goes into the chest, but more comes out. Another recoil, a little bit of air goes in, and another chest compression and more air goes out. So in this amount here, this is the total volume below the curve from the inspiratory part versus the expiratory part. So the expiratory part is larger, which gives you this net loss of 4.5 mils per kilo per 3-to-1 cycle in this model. So, in summary, we can say that higher chest compression to ventilation ratios did not improve outcomes in the models. CCAV was no advantage. Maybe there's a higher ventilation rate needed. There's mathematical models out suggesting we need higher chest compression rates, which can help to optimize systemic perfusion, and that our chest compression rate actually depends on body size and weight, and the rate should be around 180 per minute for term infants and even higher for preterm babies. Now, simulation studies have tried to examine this, and they compared, for example, 90 to 120 chest compressions per minute and found that there is faster fatigue when you use higher chest compression rate, and at a rate of using 3-to-1, your fatigue sets in. If you use a rate of 90 chest compressions a minute, your fatigue sets in roughly around 3 minutes, and if you use 120, your fatigue sets in already around 2 minutes. So there's a significant increase in fatigue when you just increase your rate by 30 chest compressions per minute. The staff asked what rate they prefer. 90 was the most preferred number of chest compression. Similar things, force measurement of using 90 to 120 chest compression per minute rates showed that 90 will be the least fatiguing chest compression rate, and it's the one which should be continued to be used. In addition, there was also some alternative methods used, in particular in a ventricular fibrillation model of adult cardiac arrest, which demonstrated that if you do chest compression over ventilation, so you do basically combine both, you have an increased neurological intact survival in PIC. Similar, if you do chest compression and ventilation simultaneously at high airway pressure, it will improve your ROSC. And that's basically one of the things we examined over the last few years, where we looked in a study where we compared 3-to-1 with 90 chest compressions and 30 inflations per minute. As the guideline says, there's 120 events per minute. We did 120 chest compression in the other group, where we combined chest compression with a sustained inflation as a high airway pressure. And what we found is that if you do CC plus SI, your ROSC is significantly improved. It was 38 seconds in our model compared to 143 seconds. Similar with survival, we had a significantly improved survival, 7 of 8 versus 3 out of 8. Because of how we did the study, the oxygen requirements were significantly reduced because we only started oxygen 30 seconds after start of chest compression. It's only 3 and 8 versus 8 and 8 in the 3-to-1 group. 30 seconds afterwards, epinephrine would have been given. None of the PICs in the CCSI group required epinephrine, whereas 7 of 8 PICs in the 3-to-1 group required epinephrine. It also significantly improved minute ventilation and alveolar oxygen delivery. I think one of the most important parts was that the CC plus SI allowed passive lung aeration, which means when you squeeze the chest, air was forced out of the chest, and during chest recall was passively air drawn back into the lung. And it would look like this, where you have your PPV initially, and then you start chest compression to deliver sustained inflation, and every time you squeeze the chest, air is pushed out, but when you release the chest, and the chest recoil, air is drawn in again, and this was going on throughout the duration of the sustained inflation. And the chest compression, which allowed us, if you did 120 chest compression a minute, allowed to give us 120 inflations a minute. Therefore, significantly increased minute ventilation. Now, I showed you before that if you're doing 3-to-1, you have a lung de-recruitment with each cycle of up to 4.5 mils of tidal volume. Now, in the CC plus SI group, we did not see any of these issues. We saw similar amount of tidal volume going in and similar amount of tidal volume coming out, and sometimes even a slight increase in tidal volume going in, which was there's kind of a net increase of tidal volume of 1 to 2 mils in total, which over time can help FRC establishment as well as improve lung aeration. Critics would say, well, you use 120 chest compressions per minute. The mathematical model says higher one is better. So maybe it wasn't your new technique, or combining these techniques. Maybe it was because the chest compression rates were higher. So second study compared then using the chest compression plus SI and using 90 and 120 chest compressions per minute, and they found similar time to ROSC, similar time to survival rates, but more importantly, from a cardiovascular perspective, the CC-SI 90 per minute had better carotid blood flow, better mean arterial pressure, improved changes in ejection fraction, and improved cardiac output, which you can hypothesize is because there was more time for filling the heart between the chest compression, so that there was more blood being delivered through the system, which also helps to achieve ROSC. So 90, as we can say, is equal to 120 when you use CC plus SI. Now we also compared that to using 3-to-1 chest compression to ventilation ratio and found similar results to our previously reported study where we used 120 chest compressions per minute and CCSI. So in that study, ROSC was significantly decreased. Once again, significantly less needed oxygen, and also they needed less epinephrine. And once again, there was improved respiratory and hemodynamic parameters in the SI plus CC90 group. A small human pilot study done to see if that can be translated into the delivery room found similar results in preterm babies less than 32 weeks. The ROSC was 31 and with a standard deviation of 9 seconds in the CCSI group and 138 plus or minus 72 seconds in the 3-to-1 group, which was significantly reduced. And overall, only one infant in total received epinephrine, and no secondary outcomes were different in any of these in this pilot study. Now, the current recommend 90 to 30 manual inflations, 90 chest compressions, 30 manual inflations in the 3-to-1 chest compression to ventilation ratio. You should synchronize it to reduce any potential of interference with tidal volume delivery, hence impairment of oxygen delivery. Most effective ratio remains controversial, and once chest compression has started, 100% oxygen should be used. Now, so far, there's no human data on how much oxygen should be used during chest compression in the delivery room, because it's, once again, a really hard topic to do. However, there's a total of 3 animal studies available, for which a team decided to do a meta-analysis. They included 100 asphyxiated piglets and showed that the time to ROSC as well as mortality were similar in newborn piglets when they received chest compression with either 21 or 100% oxygen, which indicates that 100% oxygen is as effective. 21% oxygen is as effective 100% when neonatal chest compression is needed. And you can see that here in the forest plots, which shows that in these studies there is no difference between the time of ROSC or mortality between the groups, not favoring either 21 or 100% oxygen because the diamond crosses the midline. Now, what's the plan for the future? Currently, we're working on starting a randomized controlled trial, which is called SURVIVE. It's sustained inflation and chest compression versus 3:1 chest compression to ventilation ratio doing cardio-pumonary resuscitation of asphyxiated newborn. It's registered, and we started to invite centers. We're currently at around 16 centers who agreed to participate, and we hope to start within the next 3 months recruiting our first patient. This is just a brief overview about the study. We will require roughly 120 infants to find 25% reduction in return of spontaneous circulation, which we found clinically significant, and our primary outcome will be return of spontaneous circulation. For now, I think we stick with the guidelines. What the guidelines recommend: the 3:1 chest compression to ventilation ratio, synchronize it, do not impair tidal volume delivery, and use 100% oxygen latest once we start chest compression. With that, I would like to thank everybody for your attention. You can follow us on Twitter or on our webpage, as well as this talk will be uploaded to our YouTube channel. I would like to say thanks to everybody in our team. Without this, the work would not be possible. As well, I would like to thank to our funding agencies. And with that, I'm happy to answer any questions. Thank you.